Role of sonography in interpretation. For that, we have invited Dr. Sarah Nadeem. Dr. Sarah Nadeem has been very kind because she has flown all the way from Houston, Texas to teach us on this important topic. Dr. Sarah is a renowned endocrinologist and she has special interest in diabetes technology and women in academia. Please welcome Dr. Sarah Nadeem.
Thank you. Thank you, Sumera, and thank you to PES for inviting me for today's talk. I'll be going over thyroid nodules and what the role of sonography is for interpretation, and then we'll talk a little bit about molecular testing as well as requested. So this is the overview of my talk, initially talking about what do we evaluate clinically when we're talking about thyroid nodules, when do we do an ultrasound, when do we do an FNA or just monitor, and role of molecular testing. So the most recent guidelines from the American Thyroid Association are a bit old. They are in the process of being revised and we've had some updates, but I'm going to be referring to this mostly during my talk, and I'll give you the references as we proceed. So we start with the first case, 37-year-old woman who presents with neck swelling, and most of you in your general clinics will see commonly patients who will either notice a swelling or somebody in their family will notice that their neck is bigger than before, otherwise feels well. I always tell my fellows, always ask about the 3 Ds, dyspnea, dysphagia, dysphonia, if there's any kind of thyroid enlargement, and then do your examination. So how I was trained in fellowship is I always do it from the front. I know when I was in medical school, people used to get failed if they examined the neck from the front. But I feel like if I can see the thyroid, I can do a better job. In my fellowship, my 3 years, that's what I did. So I teach my fellows, do whatever feels more comfortable to you. If you feel like you can feel it better from behind the person, do that, or do it from the front. But I always warn the patient that I'm going to be examining their neck and so forth. So you examine and you feel like there's diffuse swelling. You can't really feel a discrete nodule. That's another thing I want to mention. A lot of times we'll say, I feel a 1 centimeter nodule. Nobody can actually feel a 1 centimeter nodule. It's more of your imagination. Usually 1.5 centimeter or higher, I say 2 centimeters. Like our fingers really can't feel anything smaller than that. Once you know that there is something on the ultrasound, you may imagine you're feeling it, but you're just feeling, I say I feel nodularity, but I cannot feel a discrete nodule. That's how I put it in my notes. So history, examination, and then these were the labs, right? So I've put 3 options of labs, right? If it's the same patient, normal TSH. Second, with the same patient, but here, let me use the pointer, with the suppressed TSH. And third would be a TSH which is elevated, right? So what would you do with the first TSH? Ho gaya. Mil gaya. Khair hai. Thank you. The fellows, what would you do as a next step with this patient? You feel some nodularity, but they have a normal TSH. The next step would be? Okay, and how would you do differently with the second situation? Scan first, okay. And what about TSH, which was 9? Would you do a scan? Ultrasound. So I'm glad you have that right, because we see a lot of patients who present, the first thing is everybody gets a thyroid scan. And that is kind of one of the things I really wanted to kind of highlight. So thyroid sonography or thyroid ultrasound, as you guys rightfully marked out, is the first choice in patients with known or suspected thyroid nodules. So with known nodules, these are patients who may have had a CT scan or a neck ultrasound after a stroke and they discovered a thyroid nodule. So always do a dedicated thyroid study with survey of the cervical lymph nodes as your first step, not a thyroid scan. And what is the appropriate lab and imaging evaluation? So these are scripts from the ATA guidelines that I've actually put there. So just jumping here, if the serum TSH is normal or elevated, a radionuclide scan should never be performed as the initial imaging. So that's something I think as endocrinologists we are aware of, but it's our duty to educate our primary care physicians and internists as well that thyroid scan nahi karna. Thyroid scan is a functional test. It's not a structural evaluation. So serum TSH, first check the serum TSH measured during the initial evaluation if they don't have it. And if the serum TSH is suppressed, only then would you do a thyroid uptake and scan? Now we come to the thyroid ultrasound, right? That's the focus of this talk anyway. So when would we do a thyroid ultrasound, right? When you have certain questions, and that thyroid ultrasound should be able to address these questions in detail. So first, maybe they did a CT scan or they had a PET scan and there was something, they're saying thyroid nodules seen, please evaluate. So first we want to confirm with the thyroid or neck ultrasound whether there is a nodule there or not that is corresponding to the abnormality. Or the patient is saying, I have a swelling in the neck, I can't swallow, and you check it to make sure that is it a thyroid issue or not. Then you want to know what is the size of the nodule and what is the nodule's pattern, the sonographic pattern on imaging. And is there any suspicious cervical lymphadenopathy present? So always, when you're evaluating the thyroid, always have radiology evaluate for cervical lymphadenopathy. I think that's a job because we ourselves do not do the neck ultrasounds here ourselves. And sometimes in our busy clinics, we don't have the time to look at the imaging studies. So us working together with our radiology department is really key so that they understand what is the information that we would really appreciate getting on that ultrasound. And then looking to see whether the nodule is greater than 50% cystic. So is it purely fluid filled, which would be cystic, or is it more solid? And if it's located posteriorly in the thyroid gland or not. So why I've put these two factors is because these two features will decrease the accuracy of an FNA performed with palpation alone. In Pakistan practicing here, we don't always do an ultrasound guided FNA in certain centers. And that's really important because you will miss, if you're just doing it on palpation and you're doing a blind FNA, then the accuracy will be really affected if it's more than 50% cystic or if it's located posteriorly in the thyroid gland. So if you're trying to save money or you don't have access, if these two features are present, it's always worth it to invest in an ultrasound guided FNA. So you're not going in blind. So when you do the thyroid ultrasound, as I said, in radiology reports, we should have at least these three basic things. First about the thyroid, right? I'm going to go to the nodule, what they should be describing. But first, basic things, कि thyroid के बारे में वो क्या है. So thyroid parenchyma describe करें, is it homogeneous or heterogeneous? What is the overall gland size? And then we move to the nodule size, location, and the characteristics. And if there are presence or absence of lymph nodes. And these are the nodule details which are must-haves as per the ATA. Nodule size in 3 dimensions. So सिर्फ ये कह देना कि 2 centimeter nodule scene is not enough. You have to have 3 dimensionality here, right? And always if you're sticking with centimeters, then stick with centimeters throughout. If you're sticking with millimeters, because sometimes what happens is the thyroid size will be described in centimeters and then the nodule size will be described in millimeters. So that kind of throws people off, and we're always likely to make a mistake in a busy practice. So it's always, be uniform in whatever measurement that you're using. Then the location. So it's not enough to say just right or left. Say right, superior, inferior, middle, lobe, isthmus, the same, right? And description of the nodule's sonographic features and the composition, solid, cystic, etc. And I'm going to come to that in the next couple of slides. What the echogenicity is, hypoechoic, hyperechoic. What are the margins? Are they clearly well-defined margins? Are they unable to be well-defined? Presence and type of calcifications, shape of the nodule. If it's more tall, then it's wide, and the vascularity. Because on an ultrasound, on color Doppler flow, you can see that whether there's increased vascularity or decreased vascularity, and that makes a difference in what the risk of this nodule being cancerous is. Because the ultimate aim of doing an ultrasound is first to identify the nodule and then to see whether it's suspicious enough to go to the next step, which is a biopsy. So to FNA or not to FNA, right? So as per the ATA, FNA is recommended if the nodule size is more than 1 centimeter in greatest dimension with a high suspicion sonographic pattern. And I'll show you what those patterns are. Why at least 1 centimeter? As I explained to my patients also, like it's a fine needle aspiration, right? Even with that fine needle, if it's a very, very small size nodule, you won't really be able to get in the right position anyway. You might actually be biopsying thyroid tissue, normal thyroid tissue surrounding the nodule. So you need a little bit of nodule to actually get a sample from. And then anything with intermediate suspicion or high suspicion should obviously be biopsied. With low suspicion, that's a discussion that you should have with your patient. You can have patients who have a very low suspicious sonographic pattern, but they're extremely anxious, or they had somebody in their family who had thyroid cancer, and they're like, "Kaise aap sirf observe karengi? Aap biopsy kyun nahi recommend kari?" So even though the data may say that you can just observe and you don't really need to biopsy low suspicion, smaller nodule, sometimes for the patient you have to, right? Because agar unhone wo 6 mahine bahut pareshan guzarne hai, usse behtar hai ki just do the FNA, get a definitive answer so that they can rest assured as well, right? That's why it's a weak recommendation with low quality evidence, but it has to be a discussion. You can't just say कि नहीं मेरे ख्याल में आपको biopsy की ज़रूरत नहीं है. If they're anxious about it, they really need to know, then help them with that, right? So nodules which are greater than 2 centimeter with, anyway need to be biopsied. And the bigger the nodule, there's a recommendation that if it's more than 4 centimeter, even if you biopsy it, there's a great chance of sampling error. I explained to my patients that जैसे अगर suitable nodule size hoga, you get a couple of samples with the needle passes, you will get a nice overview of most of the nodule. But the bigger the nodule, if it's more than 4 centimeters, you may be sampling a lot but still be missing a lot. So in those cases, the FNA result is still taken with a touch of salt, and we'll talk about that. Okay. So the sonographic patterns, that's what I was saying. On the ultrasound, our relationship with our radiologist should be good, so that endocrine and radiology, we give each other the information that we need. So we tell them that, this is what I'm looking at. This is the past history. I think, they have a history of radiation to the head and neck, so there's a higher risk of thyroid cancer. Or, this was incidentally discovered and there's no other higher risk of cancer. You put that in the slip when you recommend an ultrasound, and then in return, we would like all of these details as well, right? So high suspicion pattern is if it's a solid hypoechoic nodule it could be partially cystic, partially solid, but mostly solid, with one of the following features, right? Irregular margins, microcalcifications, more tall than wide, rim calcifications, and evidence that it's spread outside as well. Intermediate suspicion is with smooth margins without macrocalcifications. And low suspicion, very low suspicion is, with spongiform, cystic nodules. And benign, if it's a purely cystic nodule, then that one really does not need to be biopsied because it's just fluid, it's cystic, it's 100% benign, right? So the estimated risk of malignancy is what I find interesting to answer questions for the patient. That, if I'm seeing purely cystic, less than 1% chance of malignancy. If I'm seeing something with all of these features, 70 to 90% chance of malignancy on FNA. So that's a good way to prepare the patient when you're doing the FNA as well, that unke results mein kya possibility ho sakti of cancer or not cancer. Because patients, whenever they hear the word biopsy or FNA, that's where their brain is going, and you want to make sure that they are prepared for the results. This I really like, and I actually recommend to my fellows. Even for me, whenever I have to look at thyroid images, I always kind of refer to this picture. This is from the ATA thyroid nodule guidelines, and they actually give. Some people learn, through pictures, and I learn through pictures rather than words. So it tells me, high suspicion when we are talking about it. Microcalcifications, hypoechoic with irregular margins, more taller than wide, and so forth. And when you look at benign, like I said, purely cystic nodule that you see here. So there is an increasing risk of malignancy as we are going from here up to there, okay, with all of the suspicious features there. So what would we do next, right? So you suspect a thyroid nodule, TSH is normal or elevated, right? Ab humne hyperthyroid wale hata diye isme se, and then we do a thyroid neck ultrasound. If there is no nodule, right, for example, they said CT scan with nodule hai, but you do thyroid ultrasound, neck ultrasound, there's no nodule, then there is nothing, right? You're not going to randomly start biopsying. I have seen patients who had the ultrasound, no nodule was seen, but because the nodule was seen on a CT scan, which was the initial incidental finding, they got an FNA. But FNA of what? FNA of normal thyroid tissue, and that's what the FNA result showed up. So it's excessive intervention on a patient in which there is no pathology. So trust your ultrasound, double check it, but if there's no nodule, there's nothing to biopsy, right? If you see a nodule, right, then you look at the patterns that I was describing out, high, intermediate, low, very low, suspicious, and then you decide whether you want to do a biopsy. And then the cytology should be reported by your pathologist based on the Bethesda system. And there are a bunch of different answers that you can get. And I'll go into that in the next couple of slides about what you will do next. So if it's malignant or cancerous, that's an easy answer. The extremes are easy to understand. Then you would send to surgery. If it is suspicious or atypia, undetermined significance, and so forth, this is what I'm going to talk about in molecular studies. If it's benign, no surgery. So benign, malignant, asana. If it's non-diagnostic, you repeat the FNA. Sometimes you can also do molecular studies here. But non-diagnostic, if the biopsy sample just didn't have enough cells, then you do need to repeat the ultrasound. And that can, again, a discussion between you and the patient, whether you want to do it at 3 months, 6 months, or a year. So that was the clinical evaluation we talked about. Take the history, find out the risk factors for possible thyroid malignancy. One of them is radiation to the head or neck, or family history and so forth. When to do with an ultrasound, which ones do we FNA, which ones do we just monitor. And then now I'm going to talk a little bit about the molecular testing, when and why. And we do not have that available in most places in Pakistan, but I was requested to talk about it a little bit. Hopefully we'll be getting it in the future. So molecular testing, when should we do it and why am I talking about it, right? So diagnostic categories of FNAs that I just showed, you could have non-diagnostic or unsatisfactory, just was a poor sample maybe, was too much blood, not enough cells. Benign, we know. Atypia of undetermined significance, or FLUS, follicular lesion of undetermined significance. Follicular neoplasm, or suspicious for malignancies. So 3 to 5 are the places where things are gray. We don't know what the actual answer is. So even before I send my patients for an ultrasound guided FNA, I tell them 90% of the time we'll get a definitive answer. And 90% of the time it is benign, right? About 5% of the time, and this can vary from whichever center you're at, but 5 to 10% of the time, it could be one of these, right? It could be either malignant, or it could be non-diagnostic, or FLUS, or follicular neoplasm, and so forth. And so the estimated predicted risk of malignancy with the Bethesda system, with malignant, it's close to 100%. With benign, it's 0 to 3%. But this is where, the waters are muddy. Because suspicious for malignancy, it could still be benign, but chances are that it is malignant. Follicular neoplasm, anywhere from 15 to 30%. And FLUS, anywhere from 5 to 15%. And there's no way for me to know unless I repeat the FNA or I do molecular studies. So in my practice at AKU, we used to just repeat the FNA and find out after waiting for about 2 to 3 months or so. But in the United States, we can also do molecular studies. And I'm going to share a couple of cases from there as well. So this is the recommendation from ATA about molecular studies. For a nodule with an initial non-diagnostic cytology result, you can repeat the FNA with ultrasound guidance and, if available, on-site cytologic evaluation. So it's okay. What we do here, repeating the ultrasound, repeating the FNA, is still on the same level recommendation as the molecular study, right? If it's non-diagnostic. If you have repeatedly non-diagnostic nodules without a high suspicion sonographic pattern, you may closely observe or excise for a definitive. So you've done 1, you've done 2, and 2-3 martaba, it's non-diagnostic and it's not really a biopsy problem. It's maybe the cytology itself or the features of the nodule which is giving us this result. But again, this is a weak recommendation with low quality evidence. Surgery should be considered for a histopathological diagnosis if the non-diagnostic nodule has a high suspicion sonographic pattern. So you go back from the FNA to the original ultrasound, and if the nodule has grown by more than 20% in 2 dimensions. तो ये नहीं कि 1.8 से वो 2 centimeter चला जाता है. It's actually 2 dimensions that you look at it. Okay. When you're doing ultrasound surveillance in 6 months a year. Or the clinical risk factors for malignancy are present. So I have a very low threshold of sending to malignancy people who've had, for example, partial thyroidectomy, and we are following the other nodule and they have a suspicious non-diagnostic nodule, or they have radiation to the head or neck, or any risk factors that puts them at higher risk for malignancy. It could be MEN and so forth. So for nodules with FLUS, which is follicular lesion of undetermined significance cytology, after you look at what the worrisome clinical and sonographic features were, you can repeat the FNA or do molecular testing to supplement the, what the risk of malignancy or cancer is, instead of just going straight to surgery. Again, informed patient preference and feasibility is always important to consider when you're doing shared decision making. And if you repeat the FNA cytology or the molecular testing and still you don't get a definitive answer, then you can still choose to engage with your patient, repeat surveillance, or diagnostic surgical excision may be performed. Now, this is a patient I've actually seen since January of this year, a 66-year-old woman, and I'm going to talk about molecular testing using her case. She had a thyroid nodule history, which was discovered. They thought she had a TIA. They did a CT scan, and also had COVID in the past, and they discovered an incidental thyroid nodule. The thyroid size, this is the ultrasound from January, describes the right lobe, the left lobe, the isthmus, and the texture. So these are the things that we remembered I talked about, the quality. And then they describe one nodule. So if there are more than one nodules, it's important, and it helps the clinician if they can label nodule 1, nodule 2, nodule 3, so we know which one we're talking about. Left superior, 1.4 by 1.6 by 1.2 centimeters, solid, and hypoechoic. It's not more tall than round, and they actually are putting in the numbers here for TIRAD's scoring. So, and then another TR4 thyroid nodule in the left inferior lobe described. So this one that we're talking about, the 1.6 centimeter by 1.2, they recommended on our ultrasound report. It says recommend FNA or not. And these are the images of the nodule that we're describing. This is the one. So you can see the margins are actually fairly well defined here. Mostly solid. So then comes the guidelines from the ATA, right? That when we are going forward with the FNA result, if the cytology is reported as suspicious for papillary carcinoma, surgical management should be similar to that of malignant cytology. These are the black and white cases we were talking about. And then B, this is the recommendation that we followed for this patient. After consideration of clinical and sonographic features, mutational testing or the molecular testing for BRAF or the 7-gene mutation marker should be done. So she underwent her FNA and came back suspicious for malignancy, right? And the aspirate described that there was enough cells, so it was not non-diagnostic, it was just the feature comprises of several atypical follicular epithelial cells with features which were suspicious for papillary carcinoma. And the nuclei are enlarged and so forth. Now, this patient's daughter is an internal medicine physician who came to every visit, and she was actually read up on it, and she said, Dr. Nadeem, why don't you just send us to the ENT surgeon and let's just take it out. And so I had to convince her that no, when we did the FNA, our lab keeps the sample for about 6 weeks. So the result comes back in about a week, and then if it is non-diagnostic or suspicious for malignancy, then we send them an order asking them to do the molecular testing. That way we don't need to re-biopsy for that molecular testing. So we sent it for the Thigen Next oncogene panel in March, and the results summary confirmed that she had BRAF V600E mutation, which correlates with a 95% risk of malignancy. So our ENT surgeons will not see a patient with either FLUS or with suspicion for malignancy unless all of them have had molecular testing. Because their rationale, which makes complete sense, is that, if it comes back malignant, we know for sure the extent of surgery that we are going to do. And if it does not, then, we can just do a, lobectomy or a partial thyroidectomy if needed. So this came up, and it is high risk of malignancy, right? Now, a lot of times there is pushback, and even with this patient, there was that her daughter was like, we could have just done the surgery 2 months ago, right? Why did we have to wait for the FNA and then this? So that's where your knowledge of thyroid cancer helps, right? You have to counsel the patient even beforehand. The thyroid cancer is not the same as breast cancer or colon cancer, where waiting 6 weeks will change your mortality or even the overall extent of disease. So that's important because these are important things to keep in mind, even though we are following the recommendations, to try and convince your patient that this will not harm them. Waiting for this extra step may actually help you in the long run to avoid extra unnecessary surgery. So I'm just going to summarize now. Clinical evaluation, always start with the history. So that way you will know whether there's a high risk of malignancy, and those people you have a lower threshold of sending for FNA right away or just observation. When to do an ultrasound, anytime you want to have your questions answered on those. And then FNA, and then if it's non-diagnostic, should we monitor or consider molecular testing in the future? And then how the molecular testing helps us clarify things is what I try to explain here. That's it. Thank you.